And I went ahead and hit record just so I don't forget.
Okay, and we'll give people a couple of more minutes. These are busy days with the session going on.
Yes, they are.
Let's see who we've got, Aaron. I see Mike Berry, and I see Valerie Mudd, and I see Steve Shannon. So there's 4 of us. We need one more for a quorum.
TJ just popped in.
Ah, okay, great. Yes, TJ's on. Wonderful. So we're missing Eddie Reynolds and Diane Shermer. Let's see if they. But we do have a quorum. Welcome, everyone. We'll give it another minute or two. This is the BH TAC. In case you got on the wrong plane at the passenger gate. All right, since we have a quorum, let's go on and we'll open the meeting. This is the Behavioral Health Technical Advisory Committee meeting. I think it says January 13th. It's actually March 10th, but these are the correct agenda items. I think I had sent out the correct items, but the wrong date on it. If we might have the voting members of the TAC introduce themselves, because we have a new coordinator from the Department for Medicaid Services. Erin, do you want to introduce yourself, please?
Hi, I'm Erin Vickers. I am going to be your new Charlie, and I will drop my email address in the chat so that if anybody needs to reach out to me. And I look forward to working with everybody.
Thank you very much, Erin. We appreciated all the work that Charlie did with us for years, but we look forward to working with you in that same capacity. Let's see, Mike Berry.
Good afternoon, everybody. Mike Berry, CEO of PAR, People Advocating Recovery.
Great, thank you, Mike. Val?
I'm Valerie Mudd with NAMI Lexington, the National Alliance on Mental Illness and Participation Station, a peer-run, peer-operated center, and I represent the consumer voice or a person living with mental illness like myself.
Great, thank you so much, Val. And Steve?
Steve Shannon with CARP, Association of Lebanon Mental Health Centers. Glad to be here.
And TJ?
Hello, TJ Lidovic, lobbyist for NAMI, Kentucky. We had a very successful advocacy day Tuesday and enjoyed seeing a lot of people.
Yeah, congratulations on that. I'm sorry that I wasn't able to get there, but I heard it was a rousing success.
Yeah.
Good, glad to have you. TJ is a new member of the TAC, joined us in January, actually representing NAMI, Kentucky. Eddie Reynolds. No, I guess Eddie's not available. And Diane Shermer. Okay, so we have a quorum. We're duly authorized to do business. First order of business are the approval of the minutes of our January 13th meeting, and those were circulated to you all. So I would entertain a motion from one of the voting members of the TAC, please.
Steve Shannon, so moved.
Okay, and is that you, Val? I'm sorry, who was seconding the
That was
motion?
me. Sorry. Yeah, that's Val.
Okay, great. Any additions, corrections, revisions? All right, all those in favor of approving the minutes from the voting members, please signify by saying aye.
Aye.
And opposed, like sign, and abstentions. All right. I apologize for the way I worded this next agenda item, because I made it sound like we were still waiting on data from Medicaid, and that is not the case. The Medicaid department was very responsive and great about meeting with us and explaining what they had. And so we have the data. Our little work group has not had an opportunity, I'll blame it on the session interfering, to look at that data. We will intend to give you all a status report on the data, an analysis of that data at our May meeting. So that was the agenda item. And again, my apologies. I'm sorry I confused some of the DMS folks, because it made it look like we were still waiting for data, and that was not the case. Next item is an update on claims payments for services to dual eligibles. And I don't know if there's anybody from Medicaid who has an update.
Sheila, this is Leslie. If I may share with you, I sent an email earlier. I've been working on getting you a good report for that. What I have seen so far that's been floating around is really like a change order that's not real user friendly. So I have taken it on today, and we have reached out to get our systems folks to help us pull that together, and then let us get it in a nice nutshell for you and give you a narrative to go with it. I didn't feel comfortable sending out what was in the change order, if that's okay. But I will take care of that for you, Sheila.
All right. Would it be possible for you to pull that material together and get it to me so I can distribute it sooner than our next meeting?
Probably. So what I would like to do is, if I can get, I'll try to get approval just to go ahead and post it, as well as to provide it to you, to you too.
Okay.
But we've already reached out. I'm just waiting for them to pull it together in a nice Excel spreadsheet that's understandable. Systems changes are hard enough for us to understand, so I want to make sure that it's readable, and understandable.
Yes, and I did hear from Kathy Adams of the Children's Alliance that they did get access to the list for billing purposes, the bypass list. So that was very helpful.
Yeah.
You might include that when you send out the materials,
Yeah.
or when they're posted, Leslie.
Kathy, do you know, you might have received something that looked very technical and looked like a change order. I think you might be one of the folks that received that one that's floating around.
No, the one I received did not look like a change order.
Okay, good. Okay.
And it came from, I think, Lee
Probably
Geis.
Lee Geis. Let me see if I can go back, and I'll make sure that we get a copy of that too. Kathy, do you mind just to send me the one that you have, and let me just compare that to what I'm working on?
Absolutely. I'm happy to.
Appreciate that so much. Thank you.
Thank you.
Yeah, I think it would be great, Leslie, if we could kind of settle on something that's real up to date and is uniform so that everybody's working off the same.
This project.
Yeah, and
really,
we-
I want to be honest.
We try to keep those updated, sometimes they
Sure.
change from time to time. So it's not one of those things that's, it does change. It does change when things get brought up to us or CMS may make changes. So as up to date as we can keep it once we get it going. So I appreciate that. And Kathy, if you'll send that to me, I would appreciate that information as well.
Okay, and thank you, Kathy, for doing that. I think if everybody has the same information, the bypass list, for those of you who may be new to this topic, this is really a two-part thing that we've been working on. Actually, Steve and I have been working on this for literally years, right, Steve?
Correct.
And this has to do with really two categories of people. One are the folks that are eligible for both Medicaid and Medicare. So typically those are the folks that we think of as dual eligible, but then we also have a number of folks, mostly children who have both Medicaid and also private insurance. And so Lee worked with us and we had several BH-TAC meetings and discussions about the dual eligibles, Medicaid and Medicare. And that change order was put in, and I think that things have been going along fairly smoothly. Is that accurate, Steve, on the Medicaid, Medicare folks?
Yes.
Great. So then the harder problem was around the private insurance. And because there are so many more of them, obviously, than the single Medicare coverage. But I appreciate Lee and all of her team continuing to work on that. And they have come up with a bypass list, which would allow the providers to enter certain codes so that they don't get hung up on this kind of never-ending circle of never getting an EOB that you can turn over to Medicaid to show that it's been denied. So if we can get this, it would really complete that, and we could take it off our agenda, Leslie, is what I'm looking forward to.
That's what I said today. I really want Sheila to be able to take it off of her agenda.
I'm really looking forward to that. So I appreciate your help on that.
Let me-
And,
I'll work on that. Like I said, I've already reached out and I'll try to do that as soon as possible. It'll take me a couple of days. You know how that works, but as soon as I can.
yeah, if we just don't have to wait until the May meeting, I think that would be the goal.
Yes, ma'am.
So appreciate that so much. So
Sheila,
then,
may I
sorry.
add something?
yes, who's that?
This is Kathy Adams.
Yes, Kathy.
I will say that the Children's Alliance reached out to each of the MCOs individually, and we obtained commercial bypass list from 4 of the 6 MCOs.
Wow.
Obviously, those lists aren't the same, but it does help. So there's just 2 MCOs that don't have a commercial bypass list.
Don't have one or have not provided it to you.
They don't have one.
Ah, okay.
And I asked, that they provide me with instructions on how then does someone get paid?
Right.
What's the process? And we're still a little bit confused on that because again, we had several back and forths with both of the MCOs insisting they needed an EOB and me saying we're not going to get one. So I basically told our members with those 2 MCOs, if they follow the process they've given us and they don't get paid, to shoot those examples to me so we can go from there.
Okay. And then you would in turn make sure that DMS knows about those problems. Okay.
Absolutely.
All right. It has always been a mystery to me that it is harder to get paid when people have 2 sources of insurance coverage than if they only have one. I mean, that's been the dilemma, right, Steve, for all these years?
Correct.
That they ought to have better coverage, more coverage, and it ought to be easier for providers to be sure that they get paid. So it has been a conundrum, as they say. All right. Well, thank you very much for that. On the no-show data gathering panel, I think we were looking for some information. The last time the insurers were saying they were not getting all the information they needed. For instance, what kind of visit had not been kept. And I wonder if we could get an update from DMS on that.
Sheila, this is Leslie. When I asked about that question, it was my understanding that, and I don't mean to misspeak, that some of the MCOs were going to share some information as well.
Right.
So do any of the MCOs on the call have information they can share with Sheila today?
This is,
Oh, go ahead.
well, I was going to say, Stuart Owen from WellCare real quick. Just want to point out, not for the WellCare presentation, but yes, we are getting the information. DMS is including the type of provider, the date of appointment, which has been extremely helpful. So we are getting that, and I'll wait for WellCare's turn to talk otherwise.
Okay, great. Thank you, Stuart. Let's see, Anthem. Anybody on from Anthem to give us a report? Aetna?
Hi, this is Kat Jones with Aetna. So yes, we got the new reports and we're in process of updating prior logic that takes that list of Medicaid member IDs, looks at the type of appointment missed and bumps it up against several ongoing monitoring reports that we have. We have, of course, our, it's pulling in, we're pulling in the PCP assigned if they're involved currently in targeted case management, who that case manager is, if they've had an inpatient admission within the last 30, 60, 90 days, if they've had an ER admission due to behavioral health within the last 30, 60, 90 days, if they're a SKY member, SKY program member. So, and several, if they're hitting our guardian angel report, which looks at an overdose, an ER visit due to overdose within the last 30, 60, 90 days. So we're in the process of building that out so we can utilize that list and see if they're hitting any of these other reports that we have ongoing, so we can prioritize and be strategic in how we're outreaching the members that are showing on the report for targeted case management.
So Kat, are you you're using some of your other data sources to kind of highlight or prioritize people that might have significant other issues going on?
Right, that might be at a higher risk,
Okay.
we're still, that, so we can prioritize those 300 and, for example, for March, I think it was 348 members were on the missed appointment list. So we can, be strategic and prioritize members that we know we need to attempt to outreach right away if they're hitting some of these other critical risk factors and hitting other reports. So we're really trying to be comprehensive and make the best use of this information, so we can outreach those members that are in urgent need to have case management contact and assist with whatever's going on with them.
Okay, thank you. I don't have any idea what those numbers look like. I guess I'm wondering, is there a way, Leslie, for the TAC to get just literally a report at the end of the month about how many members were referred to the MCOs for missed appointments?
I'm not sure. Angie Parker, are you on? Are you able to answer that question, or do we need to take it back?
There is a overall report, yes. It's not broken down by, it's an aggregate report for all
So
MCOs.
It's not broken down by MCO.
I'll have to go back and look on that part, but
Okay.
I know there is an aggregate report.
Okay. I guess I'm just trying to get a feel. I remember early on when you all first opened this reporting panel that Lee, I think it was Lee, presented a report that had, very, very few people on it. I think it had only been open maybe the first month or so. I guess I'm curious about whether one of the things you would hope would happen with this reporting panel and the MCOs getting more information about the people, what kind of appointment they missed, is that we would get a better handle on, what that typically looks like in a month and whether over time it goes down some. I don't know how many of these folks are repeat offenders, if you want to look at it that way, is the other thing.
Well, while we're on here, I'll see if I can locate the March report to kind of give you that idea.
Okay, that would be great. Thank you.
Mhm.
And thank you, Kat, for that report from Aetna. What about Humana? Somebody on from Humana to report?
Oh, you did? Oh, I thought I heard flowers. Oh, I thought it was flowers. I'm sorry.
Oh,
Guys, if you're not speaking, can you please mute? We're getting a lot of background noise.
yes, please mute if you're not speaking, please. And again, let me ask if anybody's on from Humana.
Yeah, this is Liz Stearman. I'm here from
Hi, Liz.
Humana. Hi, Dr. Schuster and everybody. Yeah, it's the basically the same update that we shared last time, and I sent some notes over so we can share with the minutes as well for the Humana Healthy Horizon approach. It's very similar in that we are, scrubbing that report each month as it comes in, those new additions to the reporting as far as, being able to identify which missed appointments may be behavioral health in nature has been extremely helpful in making sure that we triage the members on that report for appropriate outreach. We continue to see some providers reporting very robustly around missed appointments, while there are lots of providers that maybe aren't necessarily taking the time to fill that out. So we are definitely following up on the ones that we get notification of. We do the same thing. We're identifying those that may have multiple missed appointments. We are engaging with those that we see have case management, and those that do not have case management. We are doing outreach to try and enroll them in case management if it's appropriate. And additionally, if the barrier that's noted on the report is related to childcare or transportation or some of those other social determinant of health barriers, then we are doing outreach with our population health team. So sometimes it could be an employment coach, a housing coordinator, folks like that may be doing the outreach to ensure that we are trying to address the barriers that are keeping them from the appointment, in addition to the general regular case management.
Okay, thank you. Could you picture, Liz, and I'm not just asking Humana, but all of you, if you could picture having a report, mid-year or something, June, after the June report, maybe for our July meeting, of kind of looking at the first 6 months and giving us just an overview of numbers and the kinds of reasons and how many of them are multiple missed appointment for people. I mean, I love the idea of tying into the social determinants and seeing you all make those connections. That really makes sense to me.
Yeah, I think, if we can get really detailed specifications on exactly kind of which metrics we want to see, I think it would be pretty easy to get down to that. Do we want to see folks that were engaged in case management? Do we want to see multiple folks in behavioral health? You may have one person that may have missed both a behavioral health and a non-behavioral health appointment sometimes. And so just making sure that the request is real clear so we all report out in the same way. I'll tell you, since those indicators have been present on the report, we're seeing around 25% of reported missed appointments being behavioral health in nature.
Okay. Thank you. That's very helpful. And I agree with you. Having delved into the Medicaid data, I'm acutely aware of how important it is to be real specific about what we're asking for you all to report. That only makes sense.
Dr. Schuster, I have found a report that is broken out by reason and county, but not by MCO. I can see.
Huh. So it lists the county and it gives, did you say region or reason?
Reason.
Reason. Okay.
For example, I'm looking at one right now. It says reason, no show, no reason provider in Boone County. And there were 23 of those, and transportation issue were 2. So a total of 25 in Boone County.
Gotcha.
This report was run on March 2nd.
Okay.
For February.
Yeah. I think that would be well worth our seeing, Angie.
Okay. I will forward this to Aaron.
I
Okay.
agree, Sheila.
Get it out to
That's a
you.
good report.
Yeah, yeah, I think that would give us a real good sense because we're hoping that with telehealth and some other things that we're having fewer missed appointments for one thing. I mean, that certainly was an early report, but I think that would be a good, kind of stick in the ground for February, and then let's see where we go from there. Thank you.
Sure.
Um,
I just sent it to Aaron. I mean, if you want to see any of it on this meeting, I can do that, but.
yeah, let's see if we have time as we go along, but thank you for that.
Okay.
And then we'll get it from Aaron. Thanks, Angie. Let's see, a passport. I think I saw Liz on. I don't know who's reporting.
So, hi, this is Liz McCune. We are starting to see the reports come through now with the member names, as they mentioned a while ago, which has been very, very helpful. When those come in on the report, our operations team loads those into our system. They get passed over to the case management team. At this point in time, if we see that a member has missed 3 or more appointments, we are reaching out to them, especially if the reasons such as transportation or childcare. Those that are already assigned to case management, we put a task in our system so that it shows up for the case manager where they are asked to follow up for any missed appointment.
Okay.
We also are working on doing a summary report internally right now, and should have some summary data around this by the end of the month. So maybe
okay.
if this stays on, we might have something else to report next time.
All right. Great. Thank you, Liz. United, did I see Dr. Cook is on?
I am. Good afternoon, Dr. Schuster and
Good
everyone.
afternoon.
So for United, we equally are getting the report, and with the additional information, we're able to use the report in a obviously a more efficient way. So what we're doing is if the members we're finding have 3 or more missed appointments. Well, actually on the first appointment, we have follow-up happening. And as they continue, we see them have additional appointments, we refer them for if they're in behavioral health appointment, then they're referred to our case management team for that follow-up to happen with that team specifically. We're also trying to do an analysis of the data to see when we do our follow-up with them, do we actually reach them? Once we reach them, is there a connection to an appointment? So we're trying to develop a report to kind of track that as well. One of the things that we are looking at on the report is when we see a reschedule appointment, we're not actually counting that as a missed appointment, because we feel that if a member has called and rescheduled, then perhaps they are doing what's necessary to make sure that they get to their appointments. But we are tracking to see if that member pops up again. And so that's how we're managing it today. I think to date we had 58 missed appointments, and probably about 70% of those, well, based on the provider appointment type, it was probably 28%, but based on the providers that we see reporting, looks about 70% would be behavioral health appointments. So that's where we are.
So you're seeing more reports, Dr. Cook, from behavioral health providers?
Correct. So as we look at the report, so the report has an appointment type that will give a behavioral health indication in there, and then also has a provider name. And so if we just filter it through just the appointment type, it looks like about only 28% is behavioral health. But then when you filter it through the provider, about 70% looks like it is coming to behavioral health on this appointment. So with that, we are making sure that these members are not already in complex case management, but also doing that behavioral follow-up with that case management team.
Okay, thank you. That's helpful.
You're welcome.
And then WellCare, please.
Yeah, Dr. Schuster, this is Stuart Owen. And I want to mention, like Dr. Cook was saying, also, if we see that they've rescheduled, we think, okay, that's accomplishing, that's good. They're already rescheduling, so we're not focusing on them at all. And we had pointed out in the January meeting about how we had noticed the theme definitely of a BH diagnosis, and we're continuing to track that. We've seen that SMI diagnosis is about, we looked at the general Medicaid population versus the missed appointment population, and it's about 2.5 times more likely to have an SMI diagnosis, about twice as much prevalence of having a SED diagnosis, and co-occurring MH-SUD is 3 times the prevalence we've seen so far. And as far as the totals we've had for both the 2 months of this year, it's roughly 700. And I looked at the recent one we had. Of those, there were 700 incidences of a missed appointment. And of the recent one, there were 45 members who had multiple. They had at least 2 missed appointments on that. And then I looked at those, and of those, 82% of those who are, having the multiple missed appointments had a BH diagnosis. So, again, as we're all pointing out, that's definitely a prominent theme here. And what we're doing, similar to what others have pointed out, is if it's a behavioral health appointment that they're missing, our case management team is outreaching them, and they're also contacting those if there are individuals that are already in case management but they've missed an appointment. We're contacting them as well.
Okay.
And we've had both, like I said, both months we had about 700 incidences, January and February, as far as the volume.
700 each of those 2 months, Stuart?
Yeah, it was roughly the same. Yeah.
Okay.
A little bit higher in January. Actually, I think January might have been 750, so a little bit higher in January, came down a little bit in February.
So that's interesting that you're looking at the prevalence rate in terms of the diagnosis, SMI versus SED versus co-occurring. So I guess that makes some logical sense that the more complex, the more the person is affected by the severity of the illness, the diagnosis, or multiple illnesses, the more likely they are to miss. And I certainly agree that if and also with United, if somebody's rescheduled, certainly when I was a provider, I didn't consider that a missed appointment. If somebody reached out and said, something's come up, I'm not going to be able to make it, but I want to reschedule the appointment. So, okay, that's very helpful. So we'll think about looking at Angie's report here in a little bit, but also maybe looking toward a mid-year report for our July meeting and being very specific about some aggregate data that the MCOs could report to us. I guess my question too, and I don't know, ask Angie or Leslie, is there any way to get more providers to use the portal? I don't know. I can't remember what you all have sent out to providers to encourage them to do that, or if you've sent out anything recently.
I have not. I would have to ask if anybody on our team would happen to know that answer.
To my knowledge, there's not been anything recent that's been communicated. I would also have to defer to the MCOs to see how often they're doing the communication with providers about this as well.
Yeah, good point. Do any of the MCOs want to comment on trying to get more providers to use the reporting portal?
Hi, good afternoon. This is Christine Drake with Passport. But yes, we provide that information. We've done it in our e-news, but we also provide it in our monthly PowerPoint that we present to all providers on provider meetings, and provide that information and link to try to get that to as many folks as we can.
Okay, thank you. Anybody else? Oh, let me ask you, is that behavioral health providers, or that's all your providers?
And that is all providers.
Okay, thank you. Anybody else from the MCOs?
And this is Kat with Aetna. Oh, I'm sorry.
Oh, go ahead, go ahead.
So we've sent that out, that information back out via our Tip Tuesday fax blast to providers. But I think definitely we need to repeat that and make an ongoing schedule to do that, because we're definitely noticing just the same providers, BH providers reporting that information, versus what we would expect. Reality.
Yeah, maybe when we get to the end and we're looking at recommendations, we might have a recommendation from our TAC to the MAC that all of the TACs encourage have the MCOs and any way that the TACs can encourage their providers to use it. If we've got this tool, I mean, I like the idea that people that have multiple issues and multiple missed appointments would get some additional help, some referral on social determinant kinds of connections and case management, if that's what's needed. So if we really want our people, particularly our behavioral health people, to get to their appointments, it seems like that would be a way to do it. All right, thank you very much. We appreciate that. Our next issue is on the EMS, the ambulance transportation, and I will tell you, and I'll talk about this when we talk about the bills, but there's legislative activity around this. There's actually been 2 prior iterations of the bill, but the bill right now is House Bill 777 that's trying to attack this problem of ambulances not providing transport to move people from one level of care to another, or to be assured that our behavioral health people get ambulance transportation. That bill just passed the House on March the 7th and is headed over to the Senate. But I am continuing. In fact, Steve and I were just on a call with our CMHC CEOs, and we were talking about transportation problems. And another one of the CEOs said, you know, they just had a situation where someone was at a hospital without a psych unit and they needed them to be moved to a hospital with a psych unit, and the ambulance was called. The ambulance driver got there and said, I'm not carrying those crazy people. So I'm just not having it, folks. I'm really tired of this. I would encourage you to reach out to your legislators over on the Senate side and tell them to pass House Bill 777. And, you know, behavioral health will have a place. They're going to develop an advisory committee to look at this issue. And actually the Kentucky Mental Health Coalition will have the opportunity to have a provider on that advisory board. So people have been very deferential to behavioral health when we tell those stories that are not made up stories, but true stories. You know, people are annoyed, outraged, a whole variety of things. So I'm going to keep that issue on our agenda until we can either get this bill passed or get some resolution on it. But it is the epitome of stigma. There's no differential payment for ambulances. If it's a Medicaid patient, it's a Medicaid patient, whether they have a behavioral health or a physical health problem. So I don't know if there's anyone on the meeting that wanted to add anything around that topic or not.
Sheila, this is Leslie. Of course, we expect and hope that those folks would be transported. I don't have any updates, but I just wanted to share that with you.
Yeah, thank you. You know, many moons ago, when this first came up in the BH TAC, and I went back and looked, Leslie, it was 2018 when we started hearing about this. And we, thank you, Marcy. Marcy's just put the link to the bill in the chat. We brought it up over and over again, and we finally got the Medicaid commissioner at that point in time to say, oh yeah, well, we talked to the ambulance people and they said they would do better. I also think that there's a bill out there. It's a House bill from Representative Prunty to create a TAC for the ambulance and EMS people. I don't know, Leslie, if anybody at DMS is tracking that legislation.
I actually do remember something about that, Sheila. I can't tell you anymore, but I do remember seeing that to develop a TAC.
Yeah, I almost wish that, I hope that that bill passes. I'll have to go back and look at the number because it would be another way of getting information to and from that group if they have to listen to us at the MAC meetings.
I don't think.
Dr. Schuster,
Yeah.
Dr. Schuster, I believe, this is Stuart, I believe it's in the same bill. There was another bill, HB 505, that originally had the TAC and was withdrawn. Representative Fleming, and I think they put it in Representative Moser's HB 777 to have the TAC, the Emergency Medical Services TAC. I believe it's in there.
It does.
That
Yeah.
may be correct because I remember it was Moser. Okay.
Yeah, okay. Well, good. Thank you, Stuart.
Sure.
Because that was one of the issues. I think the ambulance folks are like, oh, well, nobody ever told us this. And I'm like, yeah, we did tell you this, or somebody told you this. So maybe 777 would solve several issues, but that's one of the reasons.
Regardless, they transport people who are ill.
Right.
They shouldn't have to be told to transport some people and not others.
Yes, that's exactly right, Steve. And over on the 202A transport issues, and Steve, I've forgotten that bill number that's out there.
730.
730. So there's a bill out there from Representatives Bray and Heverin to look at 202A transportation issues. And they are trying to move it from law enforcement to include ambulances and other providers that would be under contract from the cabinet. And one of the things that some of our advocates, Marcy was on that group, and Steve and Kelly Gunning contributed, was that, you know, people with a mental illness should be treated like people with an illness. They have a brain disorder and they should be treated as such and not as criminals carried away in the back of the, you know, sheriff's car in handcuffs. So the two issues are interrelated in many ways, and I think speak to the stigma around mental illness and the fear that people have about violence and so forth. So thank you, Marcy, for putting those in the chat. I appreciate it. All right, I have not heard from anyone about any issues with the formulary or with medications. And I don't know if anybody's on from the pharmacy department.
So Dr. Schuster, we had many meetings going on today simultaneously. So I did talk to Dr. Ali yesterday. She said that she doesn't have any new concerns that have been presented to her unless you had something that for her to look into.
No, I have not heard. And I always figure with meds that no news is good news because I usually hear when there's a problem. But I would remind you all, because there are lots of folks on here with connections with prescribers and with patients that need to get their medications, that if you run into something, please email me. And Marcy, if you don't mind putting my email in the chat, I think everybody in the world has it, but to let me know, because Dr. Ali has been incredibly responsive and has been on many of our TAC meetings in the past to answer any of these questions. So please let me know if there are any problems that are coming up around access to medications.
Sheila?
Yeah.
I actually talked to my med manager, who's an APRN, and she was, we were discussing the single formulary, and she said the problem she's had personally, and I don't know if it's because she's a nurse practitioner and not a psychiatrist, is they've been questioning her dosages when she's tried to get meds approved. And I told her that I would bring it up to the TAC. So that's the issue she's been having. Spending a lot of time where they've been questioning, you know, what she's ordering and the dosage. And she said it's just been a real mess and taken up a lot of her time.
Ask her to get in touch with me, Val, because I've not heard that. You know, a lot of you know that I work with APRNs and I've not heard that from other APR. There should not be any difference in the type of
And I
prescribing.
don't know if there is a difference. I just
Okay.
know that she personally has been having that experience.
Okay, and it's around dosages?
Yes.
Sheila, if you want to forward that to me or Dr. Ali, either one, I'll make sure that we get that followed up on.
Thank you. So Val, if you'll put her in touch with me and tell her to give me, some idea about what kinds of things, if she can provide any feedback she's gotten with the patient's name, obviously redacted, that's really helpful. Because then Dr. Ali and Leslie both have been very responsive. So let's get that taken care of. Thank you. Anybody else with medication access or formulary issues?
Hi, this is Dr. Terrio. I just wanted to throw out there that sometimes when dosages are being questioned, it's actually at the pharmacy level, because that happens to people in our clinic all the time, that you write a prescription, it doesn't go through because the pharmacist has a question about the dose. And it's covered, it's on the formulary, but for some reason, it's kind of halted if there's a new pharmacist or doesn't understand exactly, a dosage range. So I just wanted to throw that out there.
Thank you, Dr. Terrio. That's very helpful. So what would the person need to do, Dr. Terrio, if they're getting the pushback or the question? I was assuming it was at the MCO end or at the payment for the medication end.
And it could be, but I know we get a lot of trouble from certain pharmacies that they stop it because they think the dose is wrong. And unfortunately, what we have to do is call the pharmacist and say, hey, why didn't this go through? It's covered, and then just have a conversation and then it goes through. But of course, it's, time consuming.
It's very time consuming. Exactly. Yeah. Well, that's good input. From time to time, and again, one of the advantages of having these TACs is that we go to the MAC meeting. It was easier to do this when we were in person, but very often in the pharmacy TAC always has somebody, in fact, they have somebody on the MAC, and then they also have somebody who gives the pharmacy TAC reports. And there have been times when we've exchanged information or talked about some things that would be good, back and forth between our TAC and the pharmacy TAC. So that's another possibility. And I see Dr. James has his hand up, Tom.
Well, you know that I'll always have my hand up on things like this.
I thought you were just saying hi to me, Tom.
Well, that too. But as far as pharmacy goes, my very next meeting after this one is with the University of Louisville in a study on polypharmacy. We do the problems with drug interactions with adverse drug events is so significant in the cause of emergency room cases that drug use is a patient safety issue. So issues like being described may be at multiple levels along the way, but it is true that pharmacists will often stop things from a patient safety perspective until they find out what the real issues are. And it takes professionals sitting together with scientific evidence to get to the bottom and make some recommendations.
Yeah, I guess my question, Tom, and I appreciate that, and it certainly is great that we've got multiple eyes and multiple stages. But as Dr. Terrio mentioned, and I hear this from prescribers, both psychiatry and nurse practitioners, that the time involved in trying to track down on each individual prescription, excuse me, some of these issues just gets to be overwhelming. And I guess if you are talking about, excuse me, different pharmacies for different prescriptions.
Right. Oh, I agree. Certainly, because I do see patients, I have the same issues. I think the solution is going to end up being some better technology where questions can be routed back immediately, and unique patient situations that don't fall within a normal algorithm can be adjusted for.
I'm also curious because we've worked before with the Children's Health TAC. And I know U of L has been involved in looking specifically at overprescribing of psychotropic meds for
That's right.
children, but particularly children in foster care. So are you involved with that as well?
Since I see patients over at family health centers, yes, I've been bringing that information back and forth.
Has it gotten any better? I guess is my question. We haven't seen a full report for some time from that U of L group, but it certainly is concerning. And of course, there's a lot of overlap between the Children's Health group and our behavioral health group because so many kids are being seen for behavioral health issues.
I can ask that at my meeting at 4 o'clock.
Wonderful. I think we would be very interested, Tom. It used to be, I'm blocking on his name, Dave Lohr.
I was going to say, Dr. Lohr is
Yeah.
still with us. Would be a good contact.
Well, so if he's in your meeting, just ask him that I asked about it.
He's not in this one, but
been a
he and
while.
I are on others.
Yeah, it's been a while since we've had that report, but you know, that continues to be a real concern. And as a former child psychiatrist, child psychologist, I worry about kids getting labeled and, you know, overprescribed for behavior control reasons, particularly foster kids.
Yep.
Schuster, this is Kimberly Brothers with the Aetna Sky program. I'm Director of Behavioral Health here. And we are very engaged with Dr. Lohr and his team around the reduction of polypharmacy use for this population. Our quality team led by Margaret Susan Vickers is doing incredible work. And I believe in the near future, we will be able to produce some nice looking data to our DCBS partners and DMS partners around our efforts in reduction of polypharm.
Wonderful. I think we would be very interested, Kimberly, on having you all present to this TAC whenever you have that report ready.
We're very new in this business, but I will let Margaret Vickers know that her data is highly sought after.
Yeah, and I see from Claire Arendt from KHA that Dr. Lohr presented recently to their Psych CD forum. I just think that unfortunately, with the high number of kids that we have in foster care all the time in Kentucky, and I'm so glad we have a separate MCO looking at that. In fact, I've heard recently some very positive statements from a number of providers about being glad that there's a single MCO to deal with. So put us on your list when you get your report ready. Let's talk to you all about presenting to us. Okay?
Yes, ma'am.
All right. Thank
Maybe
you so
Dr.
much.
Lohr could present on his de-prescribing initiatives.
Yes.
I had a good conversation with him earlier this week, and that, you know, I think it's something we got to pay more attention to.
Well, I think the data was to lead to some interventions with prescribers about thinking differently about meds and de-prescribing and so forth. So good point, Steve.
Sheila, if you want to follow up with an email to me, I can reach out to Dr. Lohr. I speak with him on a pretty regular basis.
Okay. Great. Thank you, Tom, for bringing that up. That'll be a good connection for us, and to Dr. Terrio also for sharing the pharmacy side of this.
Good. It's collaboration.
Collaboration, that's what it's all about. The next item is also a recurrent item, and that's the increasing number and requirements of MCO audits. And Kathy, you sent me a note. Do you want to talk about what you all are seeing at the Children's Alliance?
Sure. And our Community-Based Services Council met yesterday, and all the MCO reps joined us. So we appreciate that. And we had good discussion. I think we have some very real examples, what we consider not just a representative sample, but an overkill of requesting records. We had one member that had records for 70 clients requested over a year's time. Now, each of those clients, it was a specified time period, but you can imagine trying to get the records for 70 clients, and then add on top of that, that you've probably gotten requests from the other MCOs, at least 3 or 4 of them, for audits as well. So it just is daunting for especially some of the smaller BHSOs and behavioral health MSGs to try to respond to these audits. The MCOs have been very good when we ask for the 30-day extension to get records to them in granting additional time. But in some of the requests, we're seeing records. For an example is they were auditing 11 clients and they wanted all of the records within 5 days. And it's like, that's just ludicrous to think that we could meet a 5-day turnaround for that many clients. And yes, reach out and ask for an extension, but why should we even have to go through that exercise? Why can't the turnaround timeframes be a little bit more reasonable? We did get positive feedback from members on audit experiences with 2 of the MCOs, that it was a very educational experience. It was a positive experience and a learning experience for them. But we didn't hear that with the other 4 MCOs. And probably one of the biggest complaints I heard yesterday was the fact that there is not routine follow-up and feedback following those audits. You know, it's one thing to jump through all of those hoops and get all of that information to them in a timely fashion, but then you don't get any feedback on the audit. You know, what did they find? What's good? What needs to be improved upon? And again, that was where we heard the positive feedback on 2 specific MCOs, that it was a good process. So I definitely think they're still getting inundated with lots of audit requests. And especially when you're dealing with 6 MCOs, it doesn't take much to push it over the edge. But this is at a time when we're all having a hard time attracting and keeping staff. We have very long wait lists for services. And so when we get these audit requests, it just takes up so much time and so much time away from patient care. So that's what we discussed yesterday.
Leslie, I know we've talked about this and you've explained that CMS is continuing to communicate with Medicaid and all the states that they really need to see that these audits are going on. But I think Kathy raises an interesting point, and I hadn't thought about it before, and that is, are there some minimum timelines that ought to be in place? I mean, 11 clients within 5 days seems extreme.
I would ask Angie to maybe speak about the particular reports and audits. I do know that without prior authorization being on right now, that may be increasing some audits, necessary audits, but and that's just on my side. I'm thinking without prior authorizations that there may be some increases. Angie, is there a minimum on the reporting, or are you aware?
There's not a minimum.
I heard the same thing as Kathy has. It's a ton of information, and it's a quick turnaround. Ask for an extension, you know, and again, very little feedback ever received. And it's just volumes of paper, right, Kathy? I mean, it's over and over and over stuff. So, you know, we understand, you know, prior auth has changed things, not having that requirement, but it still doesn't seem realistic that providers have to stop everything and send stuff to the MCO. You know, what MCO representative saw Capitol, he said sometimes a lot of these audits may be triggered almost as a whistleblower. I don't know if that's the case. Doesn't seem like it's all the cases, but he says sometimes when there's not a lot of feedback given on an audit, it's because it actually someone called and cited something, so they treat it as a whistleblower. I don't know if that's the case. It seems unlikely every audit would fall under that category, but
Definitely agree, Steve. And I think, again, you're an MCO and you're managing your providers and the services being provided. There's nothing that compels them to consider that provider is probably contracted with 5 other MCOs and experiencing the same thing. So I think just the simple volume that we've got 6 MCOs, and if you're contracted with all of them, that is definitely a hardship when you have audits. Because we also understand the need for them and support the need for them. But I think when, again, there's 6 different entities that you're getting audited from, it becomes overwhelming very quickly.
So it sounds like we're in a situation where the only way to push back from the provider standpoint to unrealistic either timeframes or volumes is to say to the MCO, we can't meet that. We're going to need to get an extension of X amount of time or whatever. Is the extension being honored, Kathy, Steve? I mean, when it's being made?
Oh, yes. Yes.
Okay.
but it's still at some point, even with an extension, you still have to gather everything.
Yeah.
It doesn't change the assignment, it just changes the due date.
Yeah. So Angie, there's no minimum time frame, and I guess no possibility of putting a minimum in. I thought I'd ask the question.
Something we can look at, Dr. Schuster. I think, there are different auditing reasons, and, whether or not it's a code that sparks an audit or number of claims, there's a lot of different reasons. And, Leslie did say, and with not having prior authorization there, that is one of the reasons why.
Right.
But I think Kathy and her ask yesterday in that meeting, which I attended as well, the ask to not, for each MCO to, depending on the number that they're requesting, to not put a 5-day turnaround on it, to, be a little bit more gracious in the amount of time, depending on the number of audits that is being requested.
Okay.
But yes, by all means, if it becomes over and you don't have the time to get it turned around in the time period, as ask for more time.
And it sounds like those extensions are being honored by the MCOs.
Yes.
Yes. And if they're not, you can contact me.
Well, let me put in a plea to the MCOs who are all on here, I guess, except Anthem, that look at your timeframes when you're sending that to a provider, and let's try to be a little bit realistic on both sides. I don't know what else can be done about it.
Hi, Dr. Schuster. This is David Crowley from Anthem.
Oh, hi, David.
I joined a little late. I was in another meeting, but our time frame's 30 days on those. And if there's an issue getting it in 30 days, then we'll work with you.
Okay, is that true for all your audit requests, David?
Yes.
Okay. Well, let me ask the other MCOs then. since you opened Pandora's box here.
Hi,
Go ahead.
oh, I'm sorry. This is Kat with Aetna. We have the same time frames, 30 days, and then if additional time is requested, we will definitely work with them.
Okay. And Humana? Did we lose our Humana person?
Sorry, I was getting off mute there. It was a little
Oh,
challenging.
okay.
Yes, so we, I believe ours is 30 days, but I'm going to check with our auditing team and I'll let you know if that's not the case. And again, we do have the same in place for requesting exceptions.
Okay, thank you, Liz. Passport?
Hi, this is Liz McCune. I'm going to have to confirm. We've had some transition and I just want to make sure I give an accurate answer. So I'll follow up with you.
All right, thank you. And United, Dr. Cook?
Yeah, so for our practice management auditing, I know that it's 30 days and they do work collaboratively if there's extension needed, but I do need to follow up for any of our audits to see the timeline that they're requesting. So I can follow up with that.
All right, thank you. And Stuart, WellCare?
Yeah, my understanding is 30, but I'll confirm that as well.
Okay. So it must have been an MCO from outer space, Kathy, that asked for 5 days.
I'm sure that was the case. I'm looking
or a
through the notes now.
All right, or a different kind of audit, maybe. Are there different, obviously there's different kinds of audits. There's got to be different kinds of audits, right?
Yes, there are different kinds of audits. And I know that this example specifically, you know, they were requesting records on 11 different clients for a year. And the turnaround was 5 days, so.
Okay. All right, well, 30 days sounds at least more reasonable as a starting place. All right, if you all check and there are other exceptions to that or differences, just send it to me by email if you would appreciate that. Okay. Leslie, this has been on for a long time and I hope we can get rid of it at some point.
Well, I do have some good news and forgive me. I know some folks were on the meeting with me this morning, so if I'm duplicating, just forgive me. But I do want to tell everybody that we have had some good news with CMS. They are now working with us after 14 months on this amendment. We've really started working on it now, which is such good news. They are helping us with the budget neutrality piece. Of course, we completed that budget neutrality. It's been more than 14 months ago, and really trying to synthesize it now and make sure that it's correct, and working with our partners in DBH and DOC to ensure the accuracy. And they've been great partners throughout this whole initiative. So CMS, I think I've told you this before, CMS actually said that their guidance to us could change daily or weekly, and just to be patient with them as they are still learning too. So we are supposed to be participating. When I say we, it's DMS, DOC, and DBH are going to participate in a round panel discussion with California and another advocacy group related to our initiatives. They seem very pleased with what Kentucky is trying to do, and that we've broken down the barriers and trying to work together as a team here in Kentucky. So as far as I can tell you right now, we're meeting with them on a monthly basis, but we are currently, like today, working on the budget neutrality piece with DOC. So hopefully I'll be able to give you more information. Sheila, if I may, I'm just going to tell you just real quick, just since this is the Behavioral Health TAC, that our mobile crisis intervention planning grant's going really well. And we are currently working on a needs assessment in Kentucky. That planning grant runs from September the 30th of 2021 to September the 30th of 2022. We did this in collaboration with our sister agency, DBHDID, and it's going really well. We have the utmost support for this initiative. do feel like that this will be something that we will explore after the planning grant. And it is to develop a one united integrated crisis model for Kentucky and kind of pulling all of us together. We've all got pieces into the crisis, right, model, but not a full like united crisis model. So that's kind of what we're working towards. And I just wanted to mention to you as well, so that for your knowledge, that we are currently working on the SMI SED waiver with CMS, just getting some guidance. Again, that's something very positive that we're working on, and we will have more information to come to you later. We are looking at trying to have this drafted sometime by the end of the year. Our other 1115s are due, I think, for renewal around 9/30 is when we have to start working on the drafts. So I just wanted to let you know that we're working on it. And then our CCBHC, I'm probably talking really fast, so I'm sorry. Our certified community behavioral health clinics rolled out January the 1st of 2022, and that will roll out for 8 quarters through a demonstration till 2024. And we did that in collaboration with our sister agency, Department of Behavioral Health. Again, it's going really well. We've always got growing pains and we're working through those, but again, it'll run for 8 quarters. We'll probably within the next couple of quarters start thinking about where we want to go after this demonstration. Again, I have the utmost support for that project, so I do see it going forward.
Wow.
Say it every time. The goal is 14 CCBHCs.
Yeah, we are looking, would like to expand. Pat, you remember CMS had me to base the eligibility of providers based on a 2016 application that was sent in quite some time ago, and that only included 4 of our CMHCs. And so, yeah, we would like to expand later at a later date. And feel free, anybody can reach out to me, and if with any questions related, there's a lot going on, right? And we're all starting to overlap. So even, you know, on Pam Smith's side with the 1915C waivers and the HCBS Enhanced FMAP, there's crisis funds in there that can be utilized by anybody, and feasibility studies for SMI and CD on that side as well. Housing and residential is a big piece right now, and we have many initiatives going on with housing and employment.
Okay.
Hopefully we can tie all these pieces together because we're running them at the same time and I need them to meet at some point. So very exciting times for behavioral health.
Yeah, if we can get some boots on the ground and get some housing out there for our SMI population that we've been working on for, I keep telling Steve, it's been 20 years at least that we've been working on this, on the SMI waiver. So love to see that happening. And certainly after 14 months with your 1115 on the SUD, good news that CMS is closing in with you. I assume that you see that as them closing in, Leslie,
yes.
They're working with you.
Budget neutrality is what we kind of first started seeing as our negotiating, you know, that's our kind of our first piece. And they've had some very minor questions, very easy to answer that were already in the waiver amendment itself. So the budget neutrality is a big piece. And honestly, we did that budget neutrality without any guidance because they weren't sure how to help us at the time. We did it, you know, over 14 months ago during COVID. So we're just trying to make sure that it's accurate, and we're gathering information with Department of Corrections to ensure that we've got the correct information and for it to be successful, because we really want this waiver to be successful.
Yes, we certainly do. And some of us feel like we've been part of the birthing process. I'm sure that you do, Leslie, but we've, you know, submitted comments and had it out there for, actually, it feels like longer than 14 months sometimes, but thank you for that update. I noticed that Representative Bentley is really big on the mobile crisis units. They have one at Pathways, which is his CMHC, and he had his bill to put some funding in the budget for more of those. I think just passed out of House A&R past week.
Correct.
So is that being coordinated with what you all are doing on this planning grant at all, Leslie?
I think it will be at some point. Right now, we've been really focusing on what we currently have and then also including any 988 initiatives that can connect to that. And really what we're looking at is not just in one integrated model, but to take what we have and expand it and enhance it. And that means that we have to redefine it, right? So we'll be working with all of our partners. Sheila, if you've not been contacted, I know that you and Steve were supposed to be contacted related to the needs assessment. If you haven't already, you will.
Yeah, no, I was interviewed.
Okay.
And I remember, I've been interviewed so many times on these things. I'm trying to remember. Maybe that one was on kids. Was that one on children and youth?
No, this particular, I think that might be one of the SEAC ones. This one would have come from probably Myers and Stauffer related to the mobile crisis and what services you see that we have now and where the gaps are and how we can enhance it for better quality.
Okay, I talked to somebody from
Sheila,
NK.
there were two, one for adults, one for kids.
Yes.
All right, because I talked to somebody from NKU.
Yeah, that's supposed
That
to
was the
happen
kid
now for
one.
me.
That
There
the
was an
kid
adult one. I'm not sure you could make it that day.
Okay.
And
All
can
right.
use the quality strategy, Dr. Schuster.
Yeah, that's the quality.
Oh, okay, that's right. You're right. Because you
It's
were on
totally
that one with me, Angie.
Yes, I was.
I feel a little bit like, what day is this? You know?
Yeah, I reached out to Angie the other day and I said, which one are you? There's so many going on right now, the strategies and the strategic planning. There's so much going on right now. It's hard to, and there's cabinet level and DMS level. So it's been a little bit hectic to keep up with, so don't feel bad at all.
Yeah, thank you. I will have to send you all my bill tracking grid. I almost got it finished and then I realized that I wasn't going to make it by the deadline, but let me go over a couple of things. And let me start with a bill that is relatively new, and it's Senate Joint Resolution 150, which came out of the Senate just maybe 10 days ago from Senator Douglas, who is the newest member of the Senate he took Senator Buford's place, so Nicholasville and part of Fayette County and so forth. And it would end the state of emergency around the COVID pandemic. Actually, he had the date of March 7th on there. We missed that, but it was also upon passage of the resolution. And it looked like the House wasn't going to take it up, but now they've assigned it to state government and it looks like it's going to move. So we had some questions about what happens if this ends the state of emergency prematurely, because the legislature had extended it to April 14th. And this is different, just for those of you who are as confused as I get sometimes about these. There's the state of emergency in Kentucky, and then there still is the federal state of emergency. And I understand that that's being actually extended to July, maybe. I think they have to give 60 days notice and they didn't do it. So we assume that it's going to be extended from April to July. So the question, Leslie, or for those of you at DMS is, you know, the commissioner has suspended the prior auths for behavioral health during this emergency period. So I guess I'm curious, we're all curious about what happens when the emergency period ends, and particularly if it ends abruptly, which is what would happen if Senate Joint Resolution 150 gets passed.
Sheila, it's my understanding, we haven't discussed anything specific to those being turned back on for behavioral health. Angie, I know you were going to speak a little bit about the prior authorization. I didn't mean to overspeak you if you were talking.
No, you're fine. No, Leslie is right. We would give at a minimum 30 days, regardless of when the public health emergency ends. So you would, if and or when prior authorization is still is allowed for behavioral health, then all providers would be given at a minimum 30 days notice.
Okay, and actually, was the authority under which the commissioner suspended behavioral health, was that necessarily legally part of being in the state of emergency?
No.
Okay.
No, it's my understanding, Sheila, that we've just been going over this internally with our medical directors on a monthly basis to review to see if we should turn them back on or not. So
okay.
I think behavioral health's kind of been outside the regular process.
All right, so it's not actually tied to the formal
time
legal, state of emergency, and we would be given 30 days notice.
Yes, ma'am.
Okay, great. And I'm hoping that with the report in May on the data, which is partly what prompted that deep dive into the data, the data would be part of that decision making as well. That's my hope. All right, another question about that. Kathy, this was your question. I'm not sure that I understand it, actually.
It was kind of to Marcy. Marcy made a comment that Senate Joint Resolution 150 just got passed while we were on this meeting. And it was heard today by House State Government and was passed by House State Government Committee. So I was just
for at 2 o'clock and it passed.
Yeah, they had already had their 3 readings on it.
Yeah, they had done the readings before they sent it to committee.
Yeah.
So it's passed. And so does a governor sign a Senate joint resolution?
Yes, it has to be signed by the governor. It does have to go to his desk for signature. So he will have 10 days to decide whether to sign it or to let it become law without a signature or to veto it. So you've just got the update, folks, hot off the press. And we'll have to just see what the governor's going to do, I guess, at that point then.
An interesting point from the discussion at the House State Government Committee was it was never clear whether ending Kentucky state of emergency would affect federal funding. There was arguments on both sides that it would and that it wouldn't. So that was interesting.
Yeah, I think that the Center for Economic Policy, KSAP, it's now called Kentucky Policy. I think Dustin Pugel, who's one of their senior policy analysts, had put out a blog or an email. Their analysis was that it would affect federal funding and would cause the loss of significant amounts, particularly on the SNAP side, food stamps, millions of dollars that now go to grocers and to support that program would be lost. So I guess the governor will have to decide what to do with all of that. Speaking of the SMI waiver, we had Senate Joint Resolution 72, and it passed the Senate unanimously and was heard in House Health and Family Services today and passed unanimously. So it should be voted on in the House. There was an amendment in the Senate to more spell out kinds of housing that could be included. And so it will have to go back over to the Senate for concurrence or agreement. And Steve gave scintillating testimony. So we thank you for that, Steve. It was so good that it burned the airwaves and we couldn't hear it.
The secret is don't open your mouth if it's going to pass.
That's for sure. These are some of our priority bills out of the SMI task force. So House Bill 127, which is Ken Fleming's bill brought by Judge Stephanie Burke out of District Court, who's the only one who's actually done some Tim's Law cases, had some changes to the statutory definition that would open it up to more people. Please mute if you're not muted. And it passed the House unanimously, and the Senate Health and Welfare Committee, and has gone to the floor of the Senate for a vote, not held yet. Representative Fleming also took another recommendation out of that task force to require the licensure boards for the mental health professions to either enter into a compact or to ease their reciprocity restrictions. And it passed the House unanimously, and I think passed Senate Health and Welfare Committee yesterday. So, so far we're, I think, have unanimous votes on all of these SMI task force bills. I don't think we've had a single no vote, which is wonderful. Marcy, you want to say a word about 373, which is the 988 funding mechanism?
Sure, it's kind of stuck in House A&R right now. So, but it does set up a 70-cent fee per line for cell phones, equal to that we pay for 911 statewide. That fee would be managed by a multi-stakeholder committee. So it would not be, the funds for that do not go to the general fund and get decided on every time we have a budget, which I think would be great. And really it's a both and with the general fund dollars. And that's been a message that seems to have gotten left off at times. We want to make sure that that's a both and. We need the general fund dollars that are asked for, as well as the 70-cent fee to really sustain 988 in the long run. For those who are not familiar, 988, the National Suicide Prevention Lifeline, the 800-273-8255 or 273-8255 will be changing to 988 in July per 2020 federal legislation. So it's changing whether we want it to or not. And once people remember it, right, it's an easy to remember number. We're definitely going to see an increase in call volume. So anyone who has questions, fund988ky.org. I'll drop that in the chat. That's our website for information. And if you have friends on House A&R, we'd love to have you ask them to please hear this as soon as possible.
Great, thank you. And just for those of you who may not be familiar, because of the regional distribution of the community mental health centers, each of them staffs a call center that receives those national suicide prevention calls, as well as all kinds of other crisis calls. So they would be the ones that would be receiving the calls from 988. So Kentucky is really in the catbird seat in terms of having these calls answered locally, where there are local resources to connect the person to if they need that. So your call to 988 would not be answered in New York or Miami or someplace else. So that's part of that funding goes to make sure that those call centers are appropriately staffed.
Yes, thanks, Sheila, for that part. Thank you so much.
So I mentioned House Bill 777, which is the improvement to the ambulance transfer. Apparently has the BH TAC for the ambulance drivers. And again, we would have a behavioral health representative on this advisory group. It passed the House 77-15. There's been a lot of controversy. In fact, this bill has been filed as two other bills before this, and they've been withdrawn, and a new iteration has come. So the latest is 777. And I think sevens are supposed to be lucky. So hopefully we'll have a little luck getting this thing passed. Senate Bill 140 is a bill that would look very carefully at the use of step therapy. And we know that that sometimes creates a problem for people getting access to their medications. It passed the Senate and has passed the House Banking and Insurance Committee and is posted for passage maybe today, actually. House Bill 174 is a bill that had been out there for a while and didn't have much traction, filed by a Democrat. And then Representative Moser signed on as a co-sponsor, and the thing has really taken off. And House Bill 174 would require Medicaid coverage for 12 months postpartum. So if you think about the 48% of the births in Kentucky are to moms who have their health coverage through Medicaid, and then that Medicaid coverage goes away, I think 6 weeks postpartum. So there's an increasing concern about postpartum depression, which I understand now is supposed to be called perinatal depression and anxiety disorders, because it's not just depression, it's also anxiety. And a lot of those moms don't really recognize the symptoms and reach out for help until 10, 11 months after the baby is born. So we really want to get this coverage by Medicaid. And it passed the House unanimously on February 18th and has gone over to the Senate. There's a bill looking at telehealth, House Bill 188, and it came up, this is Representative Duplessis' bill, came out when a constituent of his whose daughter has an eating disorder was being seen at one of the few providers, by one of the few providers for eating disorders in the state, actually, is in Louisville. And the student was a college student, was in another state for spring break and needed to talk to their therapist. And the therapist said, I think I'm prevented from delivering services to you because you're in another state and I'm only licensed in this state. So it raised all kinds of questions. And I think the various licensure boards have looked at these issues kind of in various different ways. But this bill would actually prohibit the licensure boards from stopping the provision of those services if either the provider of the services or the recipient is located in a state outside of the state of licensure, which could be very helpful, I think, to some of our folks. So those are the ones I'm going to highlight. You'll see that we have lots of other bills. I will point out one, another one is House Bill 7. And you can tell from the number that it's a priority bill for the House. It is sponsored by the two top ranking House members, Speaker Osborne and Speaker Pro Tem Mead. And it is of great concern to those of us who would like to see people maintain their Medicaid coverage and maintain their SNAP or food stamp benefits. It puts a whole lot of hoops for people to jump through. And we're going to get to a period when the federal emergency period for COVID ends. They're going to be, I think the number is well over 100,000, maybe 170,000 Kentuckians who are going to need to recertify their Medicaid coverage because their income may have changed and so forth. And this would make it extremely difficult for those people to maintain either Medicaid or food stamps. So I draw your attention to House Bill 7. There are lots and lots of groups that are creating a drumbeat in opposition to House Bill 7. So I will send that grid out to you all so you can, the BH TAC doesn't formally endorse, but those are the bills that I've heard about from the behavioral health community that have been top priorities. Any others that anybody knows about that they want to add? All right. I don't
House
think.
Bill 7 has been given one reading as well.
Yeah, and it's not gone to committee yet, right, Steve?
It's gone to Health and Family Services.
Yeah, but it hasn't been heard there yet.
No, it has not been heard.
Yeah. What they're doing, if you don't follow legislation, the way the system is supposed to work is that a bill gets introduced, gets assigned to a committee. Used to be that we would have at least 1 week's notice when a bill was going to be heard in committee. It's called a posting notice. And then you could kind of gather your troops to either, get the word out to support it or oppose it. You could get people there to testify against it and so forth. Well, they've changed so many of those rules now. Most of the bills in the House are not being assigned to a committee, particularly if they're being introduced by a Democrat. So very few of the bills introduced by Democrats are even being given a chance to be heard in a committee. So you'll see on this grid when I send it out, it'll say introduced, not assigned. and those bills are just simply left there to die. They've dropped the posting rules, so at the most we get 24 hours notice that a bill is going to be on the agenda, which doesn't give us much time to get the word out, either pro or con. And the other thing that what should happen is the bill would come out of committee, and if it passes, then it would go back to the chamber and it would be given its first reading. By Constitution, you're supposed to have 3 readings before a bill is voted on, and that gives everybody in the General Assembly a chance to, number one, examine the bill and get familiar with it, because obviously not everyone is on the same committee, and number two, file amendments if they want to do so. And then you have a deliberative process where you discuss and vote on the bill. What they're doing when they want to fast track a bill is that they're giving the bill its readings before it ever gets assigned to or heard in committee. So if they want to move House Bill 7 quickly, it happened with the budget bill of all bills, House Bill 1. They gave it its readings, and then it went to the A&R committee. The A&R committee voted it out at, I think, 1:55 in the afternoon, and they went across the street to the Capitol and went into session at 2 o'clock, and it was there for the entire House to vote on. So you get very little opportunity for the members, the legislators who are not on a particular committee. Without the posting rules, you don't get any heads up about a committee sub, and they can rewrite a bill and then present it at the committee without anybody knowing what's in the new language. So it's very, very difficult this session to track and have time to rally the troops one way or the other, either to support or oppose a bill. Has there been any updated prior authorization guidance, Leslie or Angie? I don't think I've seen anything since March,
Angie,
April.
last one's April 16th or something like that.
As far as behavioral health, there is no changes.
Yeah.
Okay. All right.
Last FAQ, I think, goes through, I wanted to say April 16th.
Okay. And no changes, as we talked about before. New recommendations for the MAC. So does anybody who's a voting member of the TAC have any recommendations that you think that we ought to be making to the MAC when it meets on March 24th? I mentioned the one earlier to recommend that the MAC and the other TACs encourage providers to use I'm calling it the no-show data gathering panel. It may have a more formal name than that, to report missed appointments. Is that what it's called, Leslie? Does it actually have a name?
Sorry, I was back on mute. I'm looking. I think it was the no-show gathering panel. And Angie, I might need to ask you again. I'm sorry. Is that the correct terminology? I think.
Wait a minute. Wait a minute. I'm getting it. It is called the missed/canceled appointments.
Thank you.
You're welcome.
Missed, canceled
appointments. Yeah.
And does the provider go to, is that considered a portal to enter the information?
On Kentucky Health Net.
Okay.
It's been a while since I looked at how all this works, so I would probably need to get an update or re-educated on the process, but on how providers go in and update that.
All right. Does anybody, any of the voting members of the TAC want to make that motion? Assuming that we get the right name for the for the thing, the missed/canceled appointment portal on Kentucky Health Net.
Motion.
Second.
Who was the first? TJ?
Yes.
Okay, thank you. And Steve seconded.
Yes.
All right, any discussion? All those in favor of making that recommendation to the MAC signify by saying aye.
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 Mike, Val, you people on?
Aye. Yeah, aye.
Okay. All right. All right, motion carries. Anything else for the MAC for their March 24th meeting? All right. For agenda items for May, we're going to report on the targeted case management data. Aetna put in the chat that they could make a report on the Poly Farm, their Poly Farm report. Any other items other than carryover of some of these? All right, the next MAC meeting, March 24th, 10 to 12:30. And our next Behavioral Health TAC meeting, May 12th, and we'll go back to the 1 o'clock time. So note that we went to 2 o'clock to not conflict with the legislative committee meetings. So we'll be back at 1 o'clock. Anything else to come before the TAC? All right.
Dr. Schuster?
Yeah.
It's Liz McCune. I wanted to report back that I confirmed that for a standard audit where they might be investigating payment that's gone out, it's 30 days. There's other types of audits where it might be a prepayment audit that is 45 days.
Okay, great. Thank you. Appreciate that. All right, I appreciate, and Humana's confirmed at 30 days also. Appreciate the input from all of our MCOs. David Crowley, are you still on?
I am, yes, Dr. Schuster.
Yeah, you missed it early on. We were asking the MCOs to report on how they were using that missed appointment data. Are you all getting that at Anthem? And can you give us some idea about what you're doing with it?
Sure, we are receiving that. So we stratify that by an internal risk indicator. So we run that report up against our clinical risk indicator report. So that prioritizes the outreach. So those that are in the highest indicators, like a group 4, with the highest risk, we outreach those folks as a priority first, and work our way down to group 3 and group 2. And then we also prioritize the outreach based on how many appointments they've missed. If they've missed 3 or more appointments, those are also moved up in priority.
Okay, excellent. That's very similar to what we're hearing from the others. Aaron, do you want to post that chart or whatever it was that Angie sent you about the missed appointments?
Yes,
Can you
give
do
me
that?
just a minute.
All right, thank you. Since we're finishing early, I hate to give people extra 15 minutes to fritter away.
Can you see it?
Yes.
Okay.
Yeah. So then does it just go page by page for each county?
That's what it looks like. I can just scroll slowly and you guys can
Yeah, why don't you go to Fayette or one of the bigger counties if you can, just to get an idea.
Can this be sent to us?
Yes.
Yeah.
I'll email it to you guys as soon as we're off the call.
Okay, thank you. Yeah, I'm just curious about.
I think we just missed Fayette.
Got a little scroll happy, didn't I?
Okay, so just 13 Huh. No show, no reason provided. And Angie, remind me, what does the other mean?
It means that there's no other category that they don't know why, and they just didn't either show up and they have no reason because they didn't call to say, you know, we have to whatever, but it could just be something that the provider's putting in. You know, it is a little bit subjective when you're, you know, depending on who's entering the information.
Yeah, I'm not sure that I understand what the difference is between other and unknown.
Yeah.
Hmm.
I mean, it could be transportation, it could be, I'd have to, like I said, I'd have to look at all the reasons they have to choose from again. Re-educate myself. And that's probably something we could send to you all too.
Yeah, that'd be helpful. I mean, I think 13 for Fayette County doesn't seem to be a big number.
Yeah, I'm surprised at how few that is. Huh.
Hard to believe that's a complete number, you know? Maybe not everybody's entering the data.
Oh, that
Well, yeah,
definitely. This report is only as good as those providers who utilize it.
Right, and this is not just behavioral health, this is all missed appointments, right?
Correct.
Yeah, I think that's our point, Kathy, that people are not, was that Kathy Dobbins?
Yes.
Yeah, that people are not using it, so let's gin up a little enthusiasm for using it. Erin, if you would send it out, I'd appreciate it. Angie, if you might, and it seems like maybe Lee did this early on. Was there a screenshot that she showed us that showed us what the choices were? Maybe.
I think somebody did. It probably was Lee, or she probably got it from someone within our IT area. So I'll find it and we'll get it out to you.
Okay, that would be helpful.
Because I don't like talking about something that I should know about and I need re-educated on.
Well, and yeah, that was some time ago that we first talked to her about this, so it's a little foggy in my mind too. All right, well, thank you, Angie, for sending that over. If you could give us a little more information, that would be helpful.
I will.
And Erin, good to have you with us. We appreciate your assistance and look forward to continuing our work with you.
Thank you. You as well.
All right. You all have a good day. Good luck with the remainder of the session. We hope that only good things pass or get signed into law or whatever, and stay healthy and safe. And we'll see you all in May.
Thank you.
All right. Thank you very much. All right.
Thank you. You too.
Bye-bye.